Good day, everyone. My name is Haitham Mekkawi, and I welcome you to this teaching session on the recognition and management of asystole within the fields of anesthesia and critical care. Asystole represents the complete absence of electrical and mechanical cardiac activity, and it is one of the most challenging and life-threatening events encountered in the operating room, the emergency department, and the intensive care unit. In this lecture, we will explore how to recognize asystole promptly, how to respond using evidence-based resuscitation principles, and how to manage the underlying physiological and pathological causes that lead to this condition. We will frame the discussion within real clinical situations that practitioners in Sudan and similar environments frequently face, including resource-limited settings, delayed presentations, and the unique challenges of our healthcare infrastructure. The ultimate objective of this session is to strengthen clinical decision-making, improve the quality of cardiopulmonary resuscitation, and enhance the safety of patients under anesthesia and critical care supervision. I encourage you to listen carefully, reflect on each concept, and relate the information to your own clinical practice. Before we discuss the specific management of asystole, it is essential to understand the broader concept known as the chain of survival. This chain represents a sequence of coordinated steps that significantly influence the chances of survival in any patient who experiences cardiac arrest. In many hospitals across Khartoum, including institutions such as Soba University Hospital and Ibrahim Malik Teaching Hospital, the effectiveness of this chain determines not only the immediate outcome of resuscitation, but also the long-term neurological recovery of the patient. The first link in the chain is the early recognition of clinical deterioration. This includes identifying warning signs such as sudden bradycardia, severe hypotension, decreased level of consciousness, or abnormalities in oxygenation. Intervening during this early stage often prevents the progression to cardiac arrest. The second link is the rapid activation of the emergency response system. In the intensive care environment, this involves immediately notifying the most experienced clinician available, mobilizing the resuscitation team, and ensuring that all essential equipment, such as the Airway trolley, emergency drugs, and defibrillator, are brought to the patient without delay. The link is the delivery of high-quality cardiopulmonary resuscitation. This requires correct compression depth, appropriate compression rate, full chest recoil, uninterrupted rhythm cycles, and effective ventilation with oxygen. The quality of chest compressions remains the single most important factor during the early minutes of cardiac arrest. The fourth link involves advanced resuscitation interventions, including airway management, pharmacological therapy, and the evaluation of reversible causes that may have precipitated the arrest. Finally, the fifth link in the chain is post-resuscitation care. This includes stabilizing hemodynamics, optimizing ventilation and oxygenation, managing electrolytes and acid-base balance, and initiating targeted temperature management when indicated. The purpose of this phase is to protect the brain and prevent secondary injury after the return of circulation. Together, these links form an integrated model that guides clinicians through every stage of cardiac arrest management. A break in any part of this chain reduces the likelihood of patient survival, whereas a strong, well-coordinated chain greatly improves clinical outcomes. As we move deeper into this topic, it is important to develop a precise understanding of what asystole actually represents. Asystole is the complete absence of detectable cardiac electrical activity. This means the heart is neither contracting nor generating an effective electrical impulse. As a result, there is no circulation and no delivery of oxygen to vital organs. When we observe a flat line on the cardiac monitor, this does not immediately confirm true asystole. It is essential to differentiate genuine cardiac arrest from technical or mechanical issues that might mimic the same appearance. Loose monitoring cables, disconnected electrodes, incorrect gain settings, or electrical interference may all produce a flat trace that resembles asystole but does not represent cardiac arrest. For this reason, confirmation in more than one monitoring lead is mandatory. It is also important to distinguish asystole from very fine ventricular fibrillation. Fine fibrillation can sometimes appear almost flat, especially if the image quality is poor or the monitor is set to a low amplitude. Identifying this difference is critical because ventricular fibrillation requires electrical defibrillation, whereas asystole does not respond to shock therapy. In resource-limited settings, such as many hospitals across Khartoum, the ability to correctly interpret the rhythm and avoid inappropriate interventions can make a significant difference in patient outcomes. In summary, recognizing asystole is not merely identifying an absence of electrical activity. It requires careful assessment of the monitor, verification in multiple leads, exclusion of technical faults, and a clear distinction from rhythms that appear similar but require different management strategies. Accurate recognition ensures that the clinical team initiates the appropriate resuscitation pathway without delay. Let us now examine a practical clinical scenario that illustrates how asystole may occur during anesthesia. A 54-year-old man is undergoing a laparoscopic cholecystectomy under general anesthesia. The induction and intubation are smooth, and the initial vital signs are stable. As the surgeon begins to insufflate the abdomen with carbon dioxide, the patient suddenly develops severe bradycardia, which rapidly progresses to a complete absence of cardiac electrical activity. This situation represents a classic example of vagally mediated asystole. The rapid stretching of the peritoneum during pneumoperitoneum can trigger an intense vagal response, leading to abrupt slowing of the heart or complete cessation of cardiac activity. In many operating rooms across Khartoum, this phenomenon is well recognized, particularly during the initial minutes of insufflation. In this scenario, the capnography trace declines sharply, indicating a sudden drop in cardiac output. The electrocardiogram shows a flat line in more than one lead, confirming true asystole. The clinical team must respond immediately by stopping the insufflation, releasing the pneumoperitoneum, and initiating high-quality cardiopulmonary resuscitation. This case highlights the importance of continuous vigilance during minimally invasive surgery, the need for rapid interpretation of physiological changes, and the value of prompt, coordinated action by the anesthesia team. It also emphasizes that asystole, although rare, can occur abruptly even in elective procedures, and that the response in the first moments is critical for patient survival. When asystole is identified, the immediate response of the clinical team becomes the decisive factor in determining whether the patient will have a chance of survival. The very first action is to initiate high-quality chest compressions without delay. Compressions must be delivered at the correct depth, the correct rate, and with complete chest recoil between each compression. Interruptions must be avoided because even brief pauses reduce coronary perfusion and significantly compromise the return of spontaneous circulation. At the same time, a member of the team must confirm that the loss of cardiac activity is genuine by checking the rhythm in more than one monitoring lead. This ensures that the flat trace is not the result of loose electrodes, equipment malfunction, or electrical interference. These surgeons should immediately stop insufflation, release the pneumoperitoneum, or halt any stimulating procedure that may be contributing to vagal reflexes. Another team member must secure the airway, ensure adequate oxygen delivery, and verify antidal carbon dioxide values, which provide real-time feedback on the quality of resuscitation. During these early moments, the team leader must give clear, structured commands. This includes assigning roles, calling for emergency drugs and equipment, and ensuring that communication is concise and focused. The environment in the operating room or the intensive care unit may become tense, but effective leadership maintains order and prevents hesitation. This immediate coordinated response, rapid recognition, uninterrupted compressions, early airway management, and decisive team direction forms the foundation upon which all subsequent resuscitation efforts depend. When a flat line appears on the monitor, it is essential to avoid assuming immediately that the patient is in true asystole. A significant number of apparent flat traces are actually the result of technical errors rather than genuine cardiac arrest. The first step is to ensure that all monitoring leads are properly connected. Loose electrodes, dry gel pads, or disconnected cables can all produce a false flat line that closely mimics asystole. A quick visual inspection of the monitor connections can prevent unnecessary resuscitation attempts. Next, the rhythm must be checked in more than one monitoring lead. A single lead may fail or may display artifacts, but viewing the rhythm from multiple perspectives provides confirmation of the true electrical activity of the heart. It is also important to adjust the gain and sensitivity settings on the monitor. Very fine ventricular fibrillation may appear almost flat when the amplitude is low, and failing to recognize this pattern can lead to missed opportunities for defibrillation. Only when the rhythm is confirmed in multiple leads, all cables are secure, and the monitor settings are appropriate, can we confidently conclude that the patient is in true asystole. This verification process takes only a few seconds, but it ensures that treatment decisions are accurate, prevents inappropriate interventions, and directs the team toward the correct resuscitation pathway. To manage asystole effectively, clinicians must rapidly consider the reversible causes that may have triggered the cardiac arrest. These causes are traditionally grouped into two categories known as the H's and the T's. The first group consists of the H's. These include hypoxia, hypovolemia, hydrogen ion accumulation, also known as acidosis, hypo, or hyperkalemia, hypothermia, and in some cases hypoglycemia. Each of these problems can significantly depress cardiac electrical activity, and addressing them promptly is often essential for restoring circulation. The second group consists of the T's. These include tension, pneumothorax, cardiac tamponade, toxins, pulmonary thrombosis, coronary thrombosis, and severe trauma. Many of these conditions require immediate procedural intervention, such as needle decompression for tension pneumothorax or pericardiocentesis for cardiac tamponade. In hospitals across Khartoum, including Soba University Hospital and Omdurman Teaching Hospital, clinicians frequently encounter asystole precipitated by hypoxia, profound dehydration from heat exposure, electrolyte imbalance caused by renal disease, or chest trauma due to road traffic accidents. Recognizing these patterns is crucial. The goal during cardiac arrest is not merely to follow an algorithm, but to identify and correct a reversible cause that may allow the heart to regain spontaneous activity. For this reason, the H's and T's must always be reviewed systematically during every case of asystole. Vagal asystole is one of the most dramatic and sudden cardiac events encountered during surgical procedures. It can occur without warning and is often triggered by intense stimulation of structures that activate the vagus nerve. One of the most common settings for vagal asystole is laparoscopic surgery. When carbon dioxide insufflation begins, the rapid stretching of the peritoneum produces a powerful reflex that may cause abrupt bradycardia. If this reflex is strong enough, it may progress directly to complete cardiac standstill. This phenomenon explains why close monitoring is essential during the first moments of creating a pneumoperitoneum, especially in patients with pre-existing vagal sensitivity. A similar reflex can occur during ocular surgery. Manipulation of the extraocular muscles, pressure on the globe, or sudden traction on the optic structures can provoke the oculocardiac reflex. This reflex produces bradycardia, arrhythmias, or even asystole, and is particularly common in pediatric patients undergoing eye procedures. In both scenarios, early recognition is critical. The clinical team must immediately halt the stimulating event, whether by stopping the pneumoperitoneum or releasing tension on the ocular muscles. Oxygenation must be ensured, and if bradycardia persists, pharmacological intervention becomes necessary. Small doses of anticholinergic medication, such as atropine, are often effective in reversing vagally-mediated cardiac arrest. In many operating theaters across Khartoum, these reflexes are encountered regularly, especially in settings where patients may present with dehydration, electrolyte imbalance, or heightened physiological stress. Understanding the mechanisms behind vagal asystole allows the anesthetist to apply rapid, targeted interventions that prevent cardiac arrest or facilitate swift recovery. This slide reinforces a crucial lesson. Not all episodes of asystole arise from cardiac pathology. Some are reflexive, reversible, and highly dependent on surgical stimuli. Recognizing this distinction ensures that treatment is appropriate, effective, and timely. High-quality cardiopulmonary resuscitation is the foundation of successful cardiac arrest management. No drug, no device, and no advanced intervention can compensate for poor quality chest compressions. The first principle is maintaining the correct compression rate, which should be between 100 and 120 compressions per minute. A rate slower than this reduces forward blood flow, while a rate that is too fast prevents adequate chest recoil. The second principle is achieving the correct compression depth. For an adult patient, the chest should be compressed by 5 to 6 centimeters with each downward movement. This depth generates the pressure needed to circulate oxygenated blood to the heart and brain. Complete recoil of the chest wall between compressions is equally important. Leaning on the chest prevents refilling of the heart, resulting in a significant drop in coronary perfusion pressure. Interruptions to compressions must be kept to an absolute minimum. Each pause causes perfusion pressure to fall sharply, and several subsequent compressions are required to restore it. For this reason, rhythm checks, airway adjustments, and defibrillator charging should be organized efficiently to avoid unnecessary delays. Anti-dial carbon dioxide monitoring plays a vital role during resuscitation. Values above 10 millimeters of mercury suggest effective compressions, while persistently low values may indicate inadequate chest movement or an unfavorable prognosis. In many intensive care units and operating theaters across Khartoum, challenges such as limited staff numbers or fatigue during prolonged resuscitation can affect the quality of compressions. For this reason, compressors should be rotated every 2 minutes to maintain consistent performance. Ultimately, high-quality cardiopulmonary resuscitation is not a mechanical task, but a disciplined, coordinated effort. When performed correctly, it significantly increases the probability of achieving a return of spontaneous circulation and preserving neurological function. Pharmacological therapy plays an important supportive role in the management of asystole, but it is essential to emphasize that no medication can replace the importance of high-quality cardiopulmonary resuscitation. The primary drug used in asystole is epinephrine. A dose of 1 milligram is administered intravenously every 3 to 5 minutes during the resuscitation effort. The purpose of epinephrine is to increase coronary and cerebral perfusion pressure, thereby enhancing the likelihood of restoring spontaneous circulation. Atropine is not routinely recommended for asystole. However, it remains useful in specific situations where the arrest is clearly mediated by excessive vagal stimulation. In those cases, a dose of 1 milligram may attenuate parasympathetic tone and help restore cardiac activity. When hyperkalemia is suspected or confirmed, targeted therapy must begin immediately. Calcium administration stabilizes the myocardial membrane, while insulin administered together with dextrose helps shift potassium into the intracellular space. These interventions can be life-saving, especially in patients with renal impairment or severe metabolic disturbances. The use of sodium bicarbonate is limited to situations in which there is severe metabolic acidosis or known hyperkalemia. Routine administration is discouraged because indiscriminate correction of pH may impair oxygen delivery and worsen patient outcomes. Across many surgical and critical care facilities in Khartoum, it is common to encounter patients with electrolyte abnormalities, dehydration, or undiagnosed renal disease. In these cases, pharmacological management must be precise, deliberate, and based on the most likely reversible cause. Pharmacological therapy should, therefore, be viewed not as a standalone solution, but as an integrated component of a broader resuscitation strategy. When drugs are administered correctly and in conjunction with high-quality compressions and targeted interventions, they significantly enhance the chance of achieving a successful resuscitation. During asystole, securing the airway and ensuring adequate oxygenation are critical components of effective resuscitation. Although chest compressions remain the priority, proper ventilation supports oxygen delivery to vital organs and improves the chances of restoring spontaneous circulation. The first principle is to establish a patent airway. If the patient does not already have an endotracheal tube, the airway should be secured as soon as practical without causing unnecessary interruption to chest compressions. Experienced clinicians may perform intubation while compressions continue, while others may temporarily use a supraglottic airway device to maintain oxygenation until conditions allow for definitive airway placement. Once the airway is secured, ventilation must be delivered with controlled breaths. Excessive ventilation is harmful because high intrathoracic pressure reduces venous return, which in turn lowers coronary perfusion pressure. For this reason, ventilation should be slow, steady, and synchronized with ongoing resuscitation. End-tidal carbon dioxide monitoring is a key tool during airway management. Persistently low values may indicate poor compressions, airway obstruction, or severe metabolic compromise, while a sudden rise often signals a return of spontaneous circulation. In operating theaters and intensive care units across Khartoum, airway management during resuscitation can be impacted by the availability of equipment, staffing, and environmental constraints. This makes structured preparation essential, including immediate access to laryngoscopes, video laryngoscopy when available, suction devices, and emergency backup airways. Ultimately, effective airway and ventilation management does not compete with chest compressions. Instead, it supports the physiological goals of resuscitation by ensuring oxygen delivery, minimizing harmful pressure changes, and providing continuous feedback through capnography. When performed correctly, it becomes a vital component of a coordinated and successful resuscitation. Termination of resuscitation is one of the most difficult decisions a clinical team must make, and it requires a careful balance between medical evidence, ethical responsibility, and respect for the patient's dignity. The first consideration is the duration of the resuscitation attempt. When high-quality compressions, appropriate ventilation, and the correct pharmacological interventions have been delivered consistently for more than 30 minutes without any signs of cardiac activity, the likelihood of meaningful recovery becomes extremely low. Another important factor is the initial rhythm. Patients who present with asystole as the very first documented rhythm have significantly poorer outcomes compared with those who begin with ventricular fibrillation or pulseless ventricular tachycardia. When asystole is persistent and refractory, it is an indicator that resuscitative efforts are unlikely to succeed. Patient-specific factors must also be considered. Advanced age, severe comorbid disease, terminal illness, or documented end-of-life wishes all influence the ethical appropriateness of continuing aggressive resuscitation. These factors should be integrated into decision-making in collaboration with senior clinicians and, when possible, with the patient's family. Environmental factors are particularly relevant in resource-limited settings, such as many hospitals across Khartoum. Limited equipment, prolonged transport delays, and delayed recognition of cardiac arrest may all reduce the probability of achieving a successful outcome. Finally, the patient must be normothermic before termination is considered. Cases of hypothermia, including trauma or perioperative exposure, require extended resuscitation efforts because the physiology of hypothermia can mimic death while remaining reversible. Termination of resuscitation should never be rushed, but it must also not be prolonged without clinical justification. When the decision is made, it should be communicated clearly, respectfully, and with full documentation. Above all, the process should uphold the values of professionalism, compassion, and patient dignity. When a return of spontaneous circulation is achieved, the focus of care must shift immediately from basic resuscitation to preventing secondary organ injury. The post-resuscitation period is a fragile and unstable phase, and decisions made at this stage determine the long-term neurological and functional outcome of the patient. The first priority is stabilizing the patient's airway and ensuring adequate oxygenation. Ventilation should be adjusted to prevent both hypoxia and hyperventilation, as extremes in oxygen or carbon dioxide levels can worsen brain injury. The second priority is hemodynamic stabilization. Blood pressure should be supported to maintain a mean arterial pressure sufficient for cerebral and coronary perfusion. This may involve careful fluid administration or the use of vasoactive medications. Continuous monitoring is essential. Electrocardiography, invasive or non-invasive blood pressure measurement, pulse oximetry, and end-tidal carbon dioxide monitoring all provide real-time information that guides further management. A critical component of post-resuscitation care is targeted temperature management when indicated. Maintaining a controlled temperature helps reduce metabolic demand and may reduce the extent of neurological injury. Blood glucose should also be monitored closely. Both hypoglycemia and severe hyperglycemia are harmful following cardiac arrest, and corrective therapy should be initiated promptly. Electrolytes and acid-base status require ongoing assessment. Disturbances in potassium, magnesium, or pH may trigger recurrent arrhythmias, making early correction essential. In hospitals across Khartoum, including emergency departments and intensive care units with limited resources, post-resuscitation care must be delivered with structured prioritization. Even when advanced technology is not available, meticulous attention to oxygenation, perfusion, glucose control, and electrolyte balance can significantly improve outcomes. Finally, communication with the patient's family is vital. They must be informed clearly, compassionately, and accurately about the patient's condition, the next steps in treatment, and the potential neurological implications of the arrest. Post-resuscitation care is therefore not only a clinical phase, but a coordinated, multidisciplinary effort. When carried out effectively, it transforms the possibility of survival into the possibility of meaningful recovery. Thank you for your time, and thank you for staying with us all the way to the end of this session. If you reach this point, please remember to like, share, and subscribe to support our educational work. Before you go, I have one final question for you. What do you know about Lazarus Syndrome, the spontaneous return of circulation after failed resuscitation? If you have an answer, an experience, or even a theory, I would love to read it in the comment section. And once again, do not forget to visit our website, anesthesia.sd, for more lectures, clinical resources, and upcoming educational projects. Thank you, and I look forward to seeing you in the next session.